Welcome to ACR On Air, the official podcast of the American College of Rheumatology, where we have engaging conversations with leading rheumatology professionals on topics such as the latest research on rheumatic diseases, solutions for addressing practice management issues, legislative policies impacting patient care, and more. Here's your host.
If your clinic is anything like mine, new patients are often waiting 3, 6, or even 9 months to be seen by a rheumatologist. Do you ever wonder why? In today's episode, we'll be discussing a pressing issue facing the healthcare in the United States, the shortage of rheumatologists nationwide. With millions of Americans suffering from rheumatic diseases, the demand for specialized care has never been greater. At the same time, the supply of rheumatologists has not kept up with this demand, leaving many patients struggling to access the care they need. To discuss these topics, I'm joined by Dr. Dan Battafarano, who co-chaired the ACR Workforce Study, which aimed to understand this very complex topic. Today, we'll explore the root causes of this shortage, its impacts on patient care, and potential solutions for addressing this critical issue. Dr. Battafarano received his medical degree from the Philadelphia College of Osteopathic Medicine. He completed his internal medicine residency at Brooke Army Medical Center in 1987, just a couple of years before I did. He completed a rheumatology fellowship at Fitzsimmons Army Medical Center in Aurora, Colorado, under Dr. Sterling West. He's an adjunct professor of medicine at the University of Texas Health in San Antonio, a professor of medicine at the Uniformed Services University of the Health Sciences, and adjunct professor of medicine at the University of the Incarnate Word College of Osteopathic Medicine. Dr. Battafarano currently serves as chair, ACR Workforce Solutions Committee, and on the ARP Nominations and Membership Committee. Hang on to your hats. It's going to be a wild ride. Dan, welcome to the show.
Hello, John. It's great to see you and talk to you. This is an exciting opportunity for me.
Great. So what I want to do throughout this episode is to try to answer the question that many patients are asking and many providers are asking too. Why is the wait time for new patients to see a rheumatologist so long? I mean, I can tell you here in Boston, we have tons of rheumatologists. And patients are waiting 3 months, 6 months, sometimes even 9 months to finally see a rheumatologist for problems that they may have had for months or even for years. So that's sort of the framework of how, at the end of the episode, I hope we have an answer. But I want to start at the beginning. How has the American College of Rheumatology approached the idea of workforce and trying to better understand what the needs are? Can you talk a little bit about that, Dan?
Your framing question's quite complicated, and I think we'll elaborate on that in our discussion. But we completed a 2015 ACR Workforce Study on both adult and pediatric rheumatology, trying to project into 2025, into 2030. And we were concerned about all the things that are happening in 2023. I'm an adult rheumatologist, so it's much more natural for me to talk about adult rheumatology problems. And I know you wear both hats as pediatric rheumatology and adult, but I can address both.
Yeah, let's talk about what, the study found.
So basically in the study, one of the first things is that we tried to genuinely determine what was the total number of providers in 2015 in the United States. But then we honed in on something that was really important, and we know this in the workplace, is what is the full-time equivalent or the clinical availability of a rheumatologist. So if you're in an academic world, you might be available 50% of the time to see a patient. If you're in private practice, you're available 90% of the time to close to 100% of the time to see a patient. So there is great variation in that. But what we projected was that by 2030, for adult rheumatology, and we're halfway there, was that when you look at the supply and the demand, that our supply of rheumatologists was going to decline over time because of a lot of baby boomer retirements.
Mm.
And, we were flipping and anticipating flipping our workforce into a predominantly female workforce.
Hmm.
And those influences, along with a younger generation of rheumatologists, was going to really require, with an increasing demand of patient care and aging population, almost 100% increase in adult rheumatologists by clinical FTE availability, which is incomprehensible, right? And I may add that this is not a rheumatology alone problem, that this is a global generational transition.
Huh.
Baby boomers around the world are retiring.
Yeah.
People like me are old and cranky, John. So all of my generation are retiring yesterday, today, tomorrow, but they need to be replaced, and they're going to be replaced by predominantly a female workforce and a younger millennial workforce and younger rheumatologists than that. And the priorities of care, the access to care, priorities of life, quality of life, all these things enter into the culture of not only access to care for the patient, but also priorities of the physician in a self-preserving way, which is a smart way, quite honestly.
Yeah, let's talk about that a little bit, Dan. I've heard it said that for a lot of people in your generation, right, being a rheumatologist was sort of a vocation, right? You're called to be a rheumatologist and you devote your life to it. And now, at least, what I'm seeing with my colleagues is that yes, but it's also a job, and I have a family, and I have young kids, and I like to go out for a run once in a while, and I want to sleep in my own bed at night, and those things may be different. So while people in your generation may have chosen to see patients, like you said, 90% of the time, people in the younger generations, may be more likely to work part time. And I think the data that you presented also, especially women, seem to prefer working part time as opposed to full time. And maybe that's why, even though the numbers of rheumatologists may not necessarily be changing that much, the available FTEs, so the availability of rheumatologists to see patients, is expected to decrease over time.
Yeah, I think first, you and I know each other a long time, and for those who don't know me, I look older than you, but I think as young as you. So
I endorse that 100%.
and what I mean by that is that although I put my head down and worked hard, and then lifted my head up and said, "Oh my God, I got to get home and help my wife or whatever," I was cognizant of that as well. But I fully appreciate why my son, who's a physical medicine and rehab physician, finishing his residency in June, and all the fellows that I've worked with and residents I've worked with, I fully understand their need to decompress, to have private time, to have family time, and to not be a workaholic in the mentality of the baby boomer generation. It doesn't make sense. And quite honestly, the baby boomer docs, whether they admit it or not, sacrificed a lot outside of the workplace because of really culturally what it was expected of us as physicians. It wasn't fully determined. We just knew that we did what everybody else did.
Yeah, and I also wonder, Dan, and I'd love your thoughts on this, is whether the work is more complex or more demanding or less satisfying with the EMRs. Is the work different? And is that why people require a little bit more breathing room now than, they may have needed 20 years ago?
Undeniably, the environment of in the workplace, in my high school terms, kind of sucks a little bit. Okay, uh, or sometimes people would say on a good day it would suck less, and on a bad day it would suck more. Right. But I think that the demands in the workplace for a physician far exceed the roles of a physician, and that is demoralizing.
Mm.
And whether we are doing EMR recording for the hospital administrators to bill and code, whether we are faxing or PDFing a prior auth, which is not a physician challenging task, but it's very exhausting.
Yep.
And our pagers are going off, our cell phones are going off, our emails are clicking, we're late for a meeting, and a patient's not doing well. And those competitive things are exhausting day to day, and then it's additive year to year. So, there's two analogies I would have, and nobody would have any problem with these analogies. Okay, we shouldn't drink and drive because we're trying to multitask and we might get in an accident, and or we shouldn't run with scissors because we might fall and stab ourselves.
Yeah.
Okay, that's the environment we're living in.
Yeah.
We are at high risk to make important decisions. We are compassionate to want to be at the bedside with a patient who needs us, and we're constantly being interrupted by things that we don't value. It's just demoralizing.
Yeah. Yeah. I totally hear that, Dan. And so maybe it's something about, this generation, my generation of people, but maybe it's also all about the work that maybe the work has become, I don't know if unsustainable, but at least, a lot more things, a lot of more balls to juggle that it may have been in the past. And maybe that, that's making work somewhat less satisfying to
Well, we've
some of
we've
the,
been we've been sort of a captive audience. Here we are. A hospital doesn't exist and a clinic doesn't exist without the providers in this discussion, rheumatologists being present. And yet, we spend our time responding to all the rules and regulations and do outs and tasks,
yeah.
and that becomes the priority over patient care. So I think that finally the docs are raising their hand, voices are being heard, and there's just an essential need. And I think what's happening now is we're being overcome by events, right? Docs are retiring, sometimes early. Now all of a sudden everybody says, oh my God, we got a workforce problem. No, we've had a workforce problem. And this workforce problem hopefully will change the environment of care for both the patients and the doctors, because we will need to.
Got it. So again, setting the stage, it seems like people in your generation are retiring. There's more women joining the rheumatology workforce. More of us are deciding to work part-time or not full FTE. And as a result, the ACR expects that there will be a shortage of rheumatologists in the future. Tell me a little bit about the other side of the equation, the demand side. What does the ACR predict is going to happen to the demand for rheumatology care in the future?
This is the big challenge, and I can lump and split adult and peds. First of all, there's just at the end of the day, if we're in Boston, like you say, there's plenty of rheumatologists. If you throw a penny, you might hit a rheumatologist in the head. But a lot of them are teaching, doing research, etc. But then if you go out to Montana, if you throw a penny, you might never hear it land. And I think that in these underserved areas, which become most obvious if you go out to Utah, Wyoming, Nevada, wow, they're kind of barren rural places. But you don't have to go far from Boston to go to Maine and
Yep.
have the same challenges of rural medicine, underserved rheumatology access in Maine, which is not that far away from Boston. So we recognize that underserved is not just people who don't have health insurance. It's people who don't have access to care, regardless of whether it's in downtown Boston or whether it's in rural America. So that's number one. Number two, pediatrics is a nightmarish challenge because pediatric practice, unlike adult, is nearly 100% practiced in a pediatric or children's hospital with other colleagues. And the demands of that healthcare team are very different than adult rheumatology. So you need a social worker, a PharmD, a PT, OT, a lot of facilitation for moms and the children's. But you need a healthcare team just by definition to provide pediatric care. And having said that, people don't realize there's only 300 pediatric rheumatologists in the United States.
Yeah.
And people would throw their hands up and say, do you know what you're talking about? Like, yeah, we do know what we're talking about. And then just imagine it's not important or relevant. unless you're a mother or father who has to take off work, drive 200 miles to see a pediatric rheumatologist for your child who can't walk. And then you got to go back to the pediatrician or the family practitioner who's afraid of your child's health condition and uncomfortable with what to do. So that was already profoundly challenging in 2015. It's gotten worse for pediatrics. So, what this is really screaming for us is, oh my God, we may have to form healthcare teams and healthcare networks to actually execute care, something we've talked that talk, but not walk that walk forever.
Yeah. So the district, you're saying like there's a maldistribution of the rheumatologists that are out there. There's a shortage. As I said, there's some places where there's more shortage than others. And pediatric rheumatology, except for Boston, I think there's shortage, pretty much throughout the United States.
Well, I'm in San Antonio. It's maybe the seventh largest city in the United States. We do not have a pediatric rheumatologist.
It's crazy.
Yes.
Crazy, crazy. So are you looking for one, Dan?
Of course, we're looking for more than one, right?
Yeah. And I think one of the other challenges is specific to pediatric rheumatology. I mean, you just mentioned the huge team that is needed to provide adequate care for patients. And the other side of the equation is that the reimbursement for pediatric rheumatologists is pretty lousy. So, I can see why, there may be a shortage of rheumatologists, of pediatric rheumatologists.
Well, yeah, I don't think for our listeners, especially pediatric rheumatologists, know exactly what you just meant. Adult rheumatologists, this is foreign to them. We sort of live in a Medicare insurance based pay fee for service model, but chronic diseases for children, regardless of rheumatology or otherwise, fall under a Medicaid model in a children's hospital, and reimbursement is different, which translates to less income. How those not for profit children's hospitals run is very challenging, and that has great negative effects on recruiting subspecialists into pediatrics because they do need to make a living and pay off their medical school debt.
Yeah. So we talked a little bit about that there's not enough rheumatologists. What's happening to the number of patients over time? What does the ACR project that's going to happen to the number of patients with rheumatic diseases going forward?
Well, I think that the primary thing from an access to care, it's almost like we're going to go backwards in the delivery of health care. In other words, if you live 200 miles away from a pediatric rheumatologist and you can't get in, your child might suffer undue disability because of untimely access to care and not timely therapeutic care. The same is true for adults. I think that we don't want to minimize that older people have lived longer than children, but the same is true for adults is that if you don't get timely appropriate care, you get disability, you can't work, you can't stay married, you can't provide for your family. So we're very fearful that that's the direction we're heading in. And how do we cut this off at the pass or help facilitate those people who are distant from access to care and facilitate access to care regardless of their background?
Yeah. And I think another important thing that was really brought the point home is the increasing aging of the US population, right? And those baby boomers that are retiring, they're going to need their doctors, for their gout flares and to manage their OA and
You're hitting one of my pain points here, John. I mean, but it is true. I can't tell you how many times I've shared with some colleagues, gosh, who's going to take care of me after I've spent 40 years taking care of other people as well as I could. And
Yep.
and I don't think that rhetorical question is unfounded because the life expectancy into the 80s and 90s is real, but quality of life is the challenge.
Yeah. As rheumatologists, not only do we take care of complex patients with vasculitis and things like that, but we're often asked to try to figure out patients' joint pain, osteoarthritis, gout, things that are only going to become more and more prevalent over the next decade.
Well, I think you bring up a good point, and I think that people, payers especially, other colleagues, they just think all we do is take care of lupus and rheumatoid arthritis and whatever. But a great part of our role to the community is identifying with a patient that they don't have a rheumatic disease,
That's right.
which is so important emotionally and physically for them to move forward, or to better identify it may not be a rheumatic disease, but we think it's another subspecialty problem, or it's a variety of issues from soft tissue problems to an abnormal blood test to whatever. And here's our plan.
Yep.
And I think that when you look at access to care, rheumatologists are quite busy doing a lot of primary care, musculoskeletal medicine, both as a pediatric rheumatologist and as an adult. And if we can somehow hold hands, shake hands, form that healthcare team network where we can help facilitate and help the primary care providers get better at some of what we would consider bread and butter, rule out rheumatology disease or bread and butter musculoskeletal disease, that would open up more access to care directly to the rheumatologist.
Good point. So the workforce study, it was called the 2015 ACR Workforce Study, and we can have links to that manuscript from the ACR on our website. Came out, a couple of years later. How has the American College of Rheumatology responded to the results from this workforce study?
The American College of Rheumatology at first was mystified that the problem was projected to be so bad. And then the more they thought about it in the first year and the second year, after all of our presentations at the national meeting in 2016 and the publication of the paper, the more they realized in talking to their cardiology friends and hematology friends that, gosh, they're having all the same problems, and that our findings, our projections were not far-fetched. And quite honestly, our study that you were co-author on became sort of a blueprint or a footprint or a template for other subspecialties. And so, but the first reaction was, hey, we need to train more fellows. So the American College of Rheumatology did what they do best, which is training. So they said, hey, we just need to have John Houseman train more fellows in Boston. We need to have Dan Battafarano train more people in the Army and the Air Force. We need to have other people train more people. The problem was that it contributed to more maldistribution of care, because if you train somebody at the University of Maryland, you're not going to recruit them to the state of Montana.
Yeah.
So that we know, regardless of specialty, that it's very common that fellows or advanced training, people will stay within 100 or 200 miles of where they trained. That's very common. You're still in Boston.
Yeah.
So that what we also realized after a few years, the ACR said, this is not working. This is not going to crack the nut. This is not going to advance us forward. So they came to me after training many extra fellows, doing a lot of small projects that people were doing on their own. None of them were cohesive or unified or synergistic. And they said, we've got a bigger problem than we appreciate. And maybe we should ask Dan if he could help us, since he understands about workforce. And that's what I did starting in 2021. I got involved with a think tank of people that I selected, and we then pitched some of our vision to the American College of Rheumatology.
Great. So how are you going to fix things, Dan?
Well, we don't have a magic wand, and I think that we're always late to the party, right? We're always responding to the crisis instead of doing prevention, whether it's in medicine or prevention in terms of management. The American College of Rheumatology is sort of the umbrella over the fraternity and the sorority, so to speak, of rheumatologists. But we also know there's 50 states, and the complexity of healthcare. We've had members become non-members, and we've had state societies become more instrumental in their day-to-day living, and I understand that. But what we did is we sat down and for about 9 months came up with a vision of a multi-pronged approach, that this is not a one size fits all, but there are some core interventions that probably need to occur and can be cut and pasted around America in different regions of the United States and can be modified and effective. But we needed to come up with those 5 interventions, and I'm happy to share them with you.
Yeah, let's start with number one.
So we came up with what we called, we have a cartoon of 3 pillars on some foundations. Okay, so I'll give you our foundation of all foundations. Okay, and that this is diversity, equity, and inclusion. Okay, so we have to have a DEI foundation so that we're always cognizant, whether we're forming a committee or we're thinking about patients, that we factor in that background cultural thinking. Okay, so that's our primary foundation. We have 2 other foundations, which really were the foundations that you and I sort of have advanced our career on. The American College of Rheumatology and the Rheumatology Research Foundation. I mean, there are 2 other, but how may they help? And I'll share that with you in a minute. So our first innovation, if you will, or intervention team was to think in reference to training that if we have underserved areas, what are the most underserved first? So we analyzed all of the regions of the United States, and it was determined using a lot of variables who needs help the most right now. Okay, and so we looked at rheumatology distribution, we looked at provider patient attributes, we looked at population attributes, we looked at the number of medicines, we looked at the payer landscape, all these things that are too complex to visualize on your own. And when we did that, what popped out was that the Northwest, the Southwest, and the South Central regions of the United States were in dire need back in 2015, and now fast forward, and you were in much more problems. So to reflect that, if you go up to Washington State and you said, okay, back in 2015 you had 1.65 rheumatologists per 100,000 people. Well, now you have 0.5 rheumatologists per 100,000 people, and that projection is occurring around the entire United States. But these 3 regions, Northwest, Southwest, South Central, were in dire need for us to start to get some interventions going there. So the first thing that we did is we realized that if you don't train in your area, you can't sustain in your area. So we have valued innovative methods for standing up ACGME fellowships, both adult and peds, in underserved regions in the United States. So by chance, and with some of our advertisement, just to fast forward, we've had places like UNLV say, we want to stand up an adult rheumatology fellowship. We say, well, we do too. Okay. And you're in a great location. The community needs it. Your university wants it, blah, blah, blah. Okay. We've been approached by University of Arkansas Children's, Little Rock. They would like to stand up a pediatric fellowship. So you say, and then you say, well, we really need that. We don't fill all of our pediatric slots. The problem is if you don't have pediatric rheumatologists in the region, you're not also, we have know by experience, you're not going to recruit them. And if we think of building up a healthcare network, we want to spread our wings at arm's length and more than arm's length, at miles length, so that we can share our talents across state lines and in regions. So growing new fellowship programs in underserved regions is important, but also optimizing the APP skill set in those regions is equally important. So, you're not going to find a nurse practitioner who wants to do adult rheumatology if she doesn't have, or he doesn't have, an adult rheumatologist to work with, right? So you've got to build that. So that is a primary intervention team, and we have people knocking on our doors, and we're meeting with people, and we hope to have stood up 5, 6, 7 new programs in these underserved areas that can then spread across state lines, okay, into regionals. And it's not far-fetched when we factor in experiences that we learned in the pandemic: virtual care, virtual training, telemedicine, echo teaching programs, that these are prime time in underserved areas to excel. And people who are most short of rheumatologists are most eager to be innovative. You're not going to find a lot of innovation in Boston, even though the smartest people are there, because they don't have the motivation to do it. They don't have to do it, okay?
Yep.
But when you get to an underserved area, people are eager, both in the university and in the community, to want to play together. And that's something that's positive. Secondly, we know that we need to have how do we recruit into underserved areas? How do we provide care in underserved areas? And we really have a bigger vision than loan forgiveness, okay? We have to recruit in a life cycle recruitment model, Jonathan. Hey, med students, have you ever heard of rheumatology? Hey, graduate students in PT, OT, nurse practitioner, PA, have you ever heard of rheumatology? And we need to expose students at that level. But then we need to worry about an early career rheumatologist, a mid-level career rheumatologist, a later rheumatologist like me. How can I step down, do 1 day a week, and have fun and contribute to society and not exit the workforce?
Mm.
So to have a life cycle recruitment model with that mind, but we are going to explode what we call career connection website on the ACR website, which will then help connect all the dots from a millennial rheumatologist to a young career research rheumatologist to a IMG or farm medical graduate rheumatologist who wants to network, et cetera, et cetera. So we feel that that's critical for building the team and for enabling people to go elsewhere. The other thing under recruiting and understanding is that we are working on what we call a white paper on the value of rheumatology, the value of a rheumatologist. So we're working on this draft right now, and we're looking at what is a rheumatologist for the patient reader, how does a rheumatologist provide care, how do they affect quality of life, and then equally important, how do they impact the economy of healthcare and what's the downstream effect? So by having a rheumatologist, you don't just take care of one patient, you actually generate income for the community, jobs for the community, et cetera. We feel that that's really important as a seller for payers, CEOs, healthcare administrators and medical centers to understand that we bring great value to the clinic, but we also bring value to them as a healthcare organization.
I love it.
The other thing, when the rubber meets the road, the third pillar, if you will, is somehow how do we foster, patient-centered care, communities of care, sustain practices so that people don't jump from one practice to another? How do we enable colleagues to work part-time? How do we recruit part-timers? How do we integrate APPs? How do we shake hands with the payers? How do we have handoffs from the medcin to a clinic back to a community hospital? All those interfaces, which are really complex. But again, a young community that's in need is more eager to work together. So payers are more eager to talk than compete.
Yeah.
They're more eager to support the mission of patient care and to prevent burnout of the rheumatologists because we need them in our community. So we need to make them happy. We need to facilitate care. We need to take care non-rheumatology tasks away from them so that they can provide rheumatology care. So that's where the rubber meets the road, and that's where a lot of our interventions will overlap and interplay all at once. And then we need to train our primary care workforce, right? So if we're going to have this community where a pediatrician knows how to refer to a pediatric rheumatologist and then is willing to take care of a patient on the other end and go back and forth, we are developing some virtual training modules that are sort of just in time learning modules. Like, hey, what do I need to know about the patients in the clinic? I just want to look this up. Oh, good. Yeah, I don't have to worry about this ANA at 1 to 40. I'm going to dismiss it. I'm going to talk to my patient.
Right. Just like when to refer, but also when not to refer.
When to refer, when not to refer, and just in time answering a simple question. And
That's great.
if not, generate a telemedicine consult, bounce it off of them. And these echo programs in telemedicine, there's a lot of learning to be had through sharing. And through sharing, you create relationships. And through relationships, you create trust. And then the other thing in our learning educational model is we are going to do a lot of virtual grand rounds into IM programs, into family medicine programs, into pediatric programs. So if somebody wants to come on site and they can invite the faculty, that's fine. But we're willing to generate a backload of topics that are germane to many primary care physicians. One for exposure, but two for learning. So again, hitting them in their first, second, and third year of residency. And then this is residing on grant support as well for, rheumatologists getting a mentor grant to train in APP. Primary care can apply for a grant. These are grants that we are creating with the Research Foundation for learning to promote musculoskeletal ultrasound for primary care. That doesn't need to be a radiologist or rheumatologist task. And so if we can enable primary care people to do more, they can have more fun.
Yeah, that's great. On the previous podcast, we spoke about the role of gout management and how primary cares and advanced care practitioners can do a heck of a better job in managing gout than we can.
Yes.
And I think you're absolutely right, Dan. It's giving them the tools to be able to do that.
Yeah, and we don't need to give them a masterpiece lecture like we give to a rheumatology fellow. We need to give them nuggets and pearls of knowledge, much like you have done in your educational career, saying, hey, let me give you something that you can run with and use today. And that's what we need to share with our colleagues, not provide them overwhelming, exhausting education. But gout is a great example where it's the number one cause of inflammatory arthritis in the world, probably, and yet we still have a poor understanding at the primary care because it's in fairness to the primary care, it's not emphasized. I mean, they emphasize life and death, cancer, cardiology, GI bleed, those kind of things, and we understand that. But the breadth of healthcare is everyday medicine, and gout is one of those. There is great literature to show one of the challenges with gout patients, as you know, is medical noncompliance. And so physicians often don't have the time to facilitate urate lowering therapy in a progressive manner like it should. There are good studies that have just been coming out, particularly in Europe, in England, where having nurse practitioners facilitate that urate lowering therapy has a much greater outcome than a physician with sporadic visits.
Yeah, that's great. And I love that idea. And, especially in, I guess, raising everybody's knowledge of rheumatology up so that, primary care doctors and other, advanced care practitioners can manage many of the things that are currently being managed by us.
And we don't want them to misperceive we're dumping on them.
Yep.
We want to say, we're on the same team. Let me make this easy for you.
Yeah. Yeah.
Here's how you can help me. Here's how I can help you.
Yeah. And I love the idea also of collaboration and networking so that, if they need help in managing a complex gout patient, telemedicine or consultations with rheumatologists seems like a great way to go. Because they may need a one-time thing. It's like, how do I manage this complex patient? Here you go. Got it. I'll do it. I'll do it on my own.
Right.
Great. What are the other thoughts or that your team has come up with, Dan?
I think one thing, although we're addressing these three regions as a primary initiative, I don't want the listeners to think that we have a magic wand and we're going to fix a region. You have to select communities that are amenable to participate. So you have two primary missions. You have to train your team from rheumatology fellow to healthcare team, but you also have to sustain the workforce. So you have to have buy-in from the community, establish relationships with all of the potential stakeholders, whether they're academic institutions, payers, but also collaborating with sister societies. Big Pharma is very interested. I know that Big Pharma gets a lot of negative press because there's a lot of money involved in Big Pharma. But when you sit down with people like Genentech and Amgen and some of these companies, they're so interested in helping the community and access to care. They're fascinated by it, and they are participating in it with grant situations, 340B, Medicaid, underserved pharmaceutical programs. All these things play a role in our ability to practice and also provide state-of-the-art care.
Yeah, that's awesome. So we came up with this workforce study in 2015. It was sort of projecting what was going to happen until 2030. And then COVID happened, something totally unexpected that nobody could have ever predicted. Or I guess some people did, the one in 100-year epidemic. How do you think that has changed the rheumatology workforce, Dan?
Let me take the positives first, since there were a lot of negatives. Okay. And what I mean by the positives first, out of the pandemic experience that happened overnight when we shut down clinics and shut down training programs and blah, 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 there were two things that happened overnight. One, virtual training,
Yep.
which, oh, we can never do that. Who wants to do that? And telemedicine to provide virtual care. We can never do that because there was never any incentive to do it, right? I mean, there was no reimbursement. It was like making a phone call. There's no reimbursement for a phone call of service. So those two things became two solutions that we can now apply today that we would not have been applying if the pandemic hadn't occurred. Okay, so we got tremendous experience with virtual training and virtual care that we need to continue to carry over as part of our workforce solutions. But undeniably, the pandemic effects on the patients, I will break this into two pieces. There was an effect on the patients, decreased access to care, challenges getting their medications, and some of the medications were used for COVID therapies,
For better or for worse.
for
Yes.
better, for worse. And then the concern of COVID infections in our patients who were, in many ways, those managed by rheumatologists were high-risk patients by definition. So they were the three huge negatives on the patients, but there were many huge negatives on the providers. If you were fixed in a fixed hospital facility, you might have found yourself being a consultant in an intensive care unit for IL-6 levels and tocilizumab therapy, right? The clinics were shut down and the staff were doing telemedicine, and then the fellows their training was interrupted tremendously. And private practices were closed 4 to 8 weeks. That was not just like, oh, decreased access to care, decreased income on physicians and their families and all of their staff. And then the reality of our workforce, which is a lot of our colleagues are women colleagues. And all of a sudden, people were raising their hands saying, oh my God, being a woman professional, it's harder. Well, it's always been harder. Okay. No one recognized it. But now all of a sudden, the kids couldn't go to school. And who was the bill payer? Often it's the female professional, whether it's a rheumatologist or another profession. They're worried about running their household, childcare, running schools, all this. And then women professionals, our colleagues, had to make professional decisions again and concede that, I think I might need to go part-time. I need to do this. That not only hurt them professionally, but they wear more hats, and they had to wear those hats. And then healthcare was not ready for women. 50% of medical students graduating are women, and 50% of rheumatologists are women. And so these had a dramatic effect, not only on our workforce immediately, but it also accelerated retirements of some of those baby boomers earlier who we didn't rescue and get back.
Yep.
So it's not our imagination that the pandemic had a negative ill effect. It had a tremendous negative effect, but now we're trying to use our virtual experiences as part of our solutions.
Yeah, that sounds totally reasonable, and hopefully we can get back on track. And I wonder about the effect of the pandemic on burnout. Can you talk a little bit about that?
I think the pandemic contributed to more burnout on already a fatigued workforce. So I think that we went into the pandemic tired. We went into the pandemic with many challenges in the workplace, and then the pandemic compounded that. And so some of our colleagues tipped over, meaning with exhaustion. And certainly in the non-rheumatology specialties like emergency room, intensive care unit, we saw that happen overnight. But we went into that tired, it accelerated burnout, and then our workforce shortages compound the burnout. And burnout's such a complicated topic, but it's real. and it needs to be part of our solutions as we build healthcare teams and whatever. We don't need to tell doctors that they're wimpy and they're not resilient. By definition, we've been very durable people. We've run the marathon a long time through training, going through residency and whatnot. We are just fatigued for the wrong reasons. And so that needs to be part of our solution in the workplace.
Yeah, yeah, that's very smart. So, we talked a little, throughout this podcast, started with the question, Dan, about why is it taking my patients 3 months, 6 months, 9 months to see me in clinic? And it sounds like, we have a little bit of an answer, right? People are retiring. The younger folks that are joining the rheumatology workforce don't want to work full time
Or can't.
or can't work full time. There's increased demand for rheumatology care with the aging of the population. You also mentioned that there's a maldistribution of rheumatologists throughout the country. And we didn't get too much into pediatric rheumatology that I think has it even harder, where there's even worse maldistribution and worse shortages. As you mentioned, 300 rheumatologists for the United States is not that much. So all that sounds very depressing. So
Yes.
I want to leave this podcast in somewhat a bright light, something to look forward to. So what do you think are going to be the successes 5 or 10 years down the road that we can say, okay, we have a big problem, but these were some of the solutions that helped us the most?
I think that things take time, and we're identifying solutions a little late, but it takes a crisis to respond to a crisis. I think, though, that there's a propensity for our colleagues, and you know this and I know this, to always think that somebody else is going to fix it. And the first thing is we will get it more right, or get it more satisfying, or get it more fun if people all do their part. So that if you have rheumatologists in academic medicine trying to make learning better, more efficient, and whatever inside of their walls, that's as important as a rural community trying to make things better in their world for their patients. I think that people in communities, like I said, if you go to Maine or you go to Montana, they're more inclined to worry about taking care of the individual patient, taking care of their individual doctors, taking care of their community. When we get into these puzzle palaces of academia, people are thinking in their lane of their research grants, their clinic is busy, I don't get enough fellows in my program. We have, you and I, and many of our colleagues have been very generous with our time, but we also are smart people. We can be part of the solutions. And I think that applying a little bit of thought and working with some volunteers on our team and with the community can accelerate a 10-year story into a 6-year story or 6-year solution. We have time, if that's the right word, for our congested areas or our more populated areas on the East Coast, the West Coast, across the Great Lakes and the Central region. So we need to focus on our underserved areas, because if we can get those areas stood up, so to speak, or compensate, and what we get to is experience, we can then carry that experience and successes elsewhere when the more dense areas are more challenged.
Great. Yeah. And, personally, I love the idea of telemedicine, teleconsultations, like all of those things. I think, I've taken part in some strategies to do that and providing consultation for primary care doctors about, this is a patient that, yes, that I want to see in my clinic, or this is a patient that doesn't need to be seen by rheumatology. And providing that quick feedback to primary care doctors, I think may create an impact down the road. And I think, as you said, Dan, better training for, primary care doctors and, nurse practitioners and PAs about how to recognize rheumatic diseases and how better manage, hopefully will have great impacts in the future.
we really want to identify what I would call a super user. So if you go out to an internal medicine practice and they have 6 internists, somebody there might really like rheumatic disease. Somebody else might like infectious disease, and they can become that surrogate specialist in that area to push and pull, receive and manage complex patients, and that's true in pediatrics as well. And I think that people in primary care get tired of juggling hypertension or diabetes or the same things, and so some feel challenged. So to discover those super users can be super helpful for the specialists like you and I.
I love it, Dan. This has been a really great conversation, and it sounds like this is just the start of the conversation, right? Because I think there's a lot of work that you and me and the ACR need to do to sort of implement some of these things. So, Dan, I really thank you for your time, and I hope that we can chat again maybe in a year and seeing what progress you've made during this time.
Well, let me solicit you for some volunteers from your listeners, and if they wanted to volunteer to contribute on committees, we probably have 70 people working with us now. Okay,
amazing.
To include workforce consultant, but Connie Herndon is my right arm and is the vice president of research and workforce and whatnot, and her email is CHERNDON@rheumatology.org, and anybody interested in contributing in their region or location or community, please have them send Connie an email and we will integrate them into our workforce.
Fantastic, Dan. We'll have that up on our website, acronair.org. Thanks for your time.
Thanks so much. It was fantastic. Appreciate it.
Well, there you have it. More rheumatologists are retiring. Those entering the workforce are not planning to work full-time, all while the demand for rheumatology care is increasing. Not an easy puzzle to solve, but certainly something that needs some creative solutions. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find our show notes for this episode at acronair.org, Apple Podcast, and on your favorite podcast app. Until next time, keep cranking those RVUs, and of course, stay healthy.
Loved this episode of ACR On Air? Then be sure to subscribe at acronair.org and join us every third Tuesday for new episodes. Thanks for listening.